This section is entitled Anticoagulants, Thrombolytics, and Antiplatelet Drugs. We'll talk about which medications are commonly given and when they're given. In this section, we'll discuss anticoagulant medications, thrombolytic medications, and antiplatelet drugs. Anticoagulant medications, based on the patient as well as the medication, can be used both as a treatment for abnormal blood clotting and as for prophylaxis for patients that are at risk for developing a blood clot. For example, patients that have atrial fibrillation, patients that have a mechanical heart valve, or an inherited clotting disorder. Some of the inherited clotting disorders include factor V Leiden mutation. This is a variant of factor V that is more prone to causing clotting activation. Another is prothrombin variant, which exhibits an excessively active prothrombin molecule, and protein C or protein S deficiencies. It's important to remember that protein C and protein S, even though they are vitamin K dependent, they are also endogenous anticoagulant molecules. The coagulation cascade is very complex. It's not important for this test to remember all the different steps in the coagulation cascade, but you should be able to recognize where in the coagulation cascade are the major branch points. And you should also know the important tests that we use to measure the coagulability of blood, that is the partial thromboplastin time, the PTT, and the prothrombin time, the PT. Anticoagulant therapy is used usually through heparin and warfarin, although more drugs have become available over the last decade. Unfractionated heparin is the most commonly used anticoagulant on the market today. This medication is a liquid, and it's a large water-soluble polysaccharide molecule of varying size. It ranges from 15,000 to 20,000 Daltons. This medication does not cross the placenta, therefore it's safe in pregnancy. It must be given parenterally. When a patient actually has a blood clot and needs to be given heparin to help the body break down the clot, then the heparin must be given as a constant drip. For prophylaxis, for a patient that's at risk for developing a blood clot, unfractionated heparin can be given subcutaneously 3 times per day. The way that heparin works is by increasing the activity of antithrombin 3. This causes inactivation of thrombin and factor Xa. Heparin levels are monitored by following the partial thromboplastin time, or PTT. This is usually done approximately every 6 hours. The antidote for unfractionated heparin is protamine sulfate, which is able to bind heparin and prevent it from binding to antithrombin 3. Recently, a new form of heparin has come out called low molecular weight heparin. Another molecule very similar to this is fondaparinux. Low molecular weight heparin is a purified heparin with a molecular weight of 2,000 to 600 Daltons. Fondaparinux is a synthetic heparin with similar properties to low molecular weight heparin. Low molecular weight heparin it does bind to antithrombin 3, but it only inhibits factor Xa but not thrombin. It can be given subcutaneously or IV. Usually it's given subcutaneously. This medication can be given once a day for prophylaxis against blood clots, or twice daily if the patient has a blood clot and they need to become anticoagulated. Low molecular weight heparin cannot be monitored with a PTT blood test. Therefore, if it needs to be monitored, we can check factor Xa or low molecular weight heparin levels in the patient. Low molecular weight heparin is dosed by weight. Therefore, it cannot be used in the morbidly obese, and it is cleared renally, so it's not for use in patients that have renal failure. Some clinical uses for heparin include rapid anticoagulation for certain thromboses, pulmonary emboli, unstable angina, and open heart surgery. Heparin works very quickly. Therefore, it can be used as a bridge to long-term anticoagulation therapy, usually with warfarin. Heparin is also used for anticoagulation of women who are pregnant. Heparin is also used as DVT prophylaxis in patients who are at risk for developing a blood clot. Adverse effects of heparin include bleeding risk, and that includes bleeding into the brain as well as into the GI system. Other adverse effects include heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia, or HIT, can actually lead to thrombosis, which is HITT. This is a very feared complication of heparin, and this is basically a heparin allergy. These patients cannot receive heparin ever. Another adverse effect of heparin can include skin necrosis at the site of the heparin injection. This is an example of heparin-induced skin necrosis at the site of injection of heparin. Warfarin or Coumadin is another anticoagulant medication, except Coumadin can be given orally. It has a long half-life of approximately 30 hours. It is metabolized by cytochrome 2C9 in the liver, and it is involved in many drug-drug interactions. It is kind of contraindicated in pregnancy because it's able to cross the placenta and is a teratogen. Warfarin works by decreasing the hepatic synthesis of vitamin K-dependent clotting factors, and that includes factor 2, factor 7, factor 9, factor 10, as well as the anticoagulant molecules protein C and protein S. When patients are taking warfarin, their blood can be monitored by the prothrombin time. Most laboratories will report this as an INR. INR stands for International Normalized Ratio. A normal INR in a patient not taking Coumadin is 1.0. When a patient is taking Coumadin, you would like their INR to be between 2.0 and 3.0. This is generally considered therapeutic. In patients that have an artificial heart valve, their INR should be kept between 2.5 and 3.5. A higher INR means more anticoagulation. It is possible for the INR to become very high, 5, 10, even 15. In that case, the blood has become very thin and it's hard for the blood to clot. This would be considered a warfarin overdose. There are two major antidotes that we have for warfarin overdose, and those include vitamin K and fresh frozen plasma. Vitamin K, as you know, is slower acting, and vitamin K then is incorporated into the liver, and you must wait for the body to produce new clotting factors. Another option if a patient is actually bleeding and has a warfarin overdose is to give the patient fresh frozen plasma from another volunteer donor. Fresh frozen plasma provides clotting factors if a patient has severe bleeding. Clinical uses of warfarin are for long-term anticoagulation. These patients are at high risk for thromboemboli, including congenital thrombopathies, mechanical heart valves, and atrial fibrillation. Warfarin interacts with a lot of other drugs, and its effect is also influenced by diet. If a patient takes warfarin, they need to keep their vitamin K intake constant every day. If a patient were to all of a sudden eat more vitamin K-rich foods, the effect of their warfarin would decrease, because warfarin works by inhibiting vitamin K-dependent processes. Certain drugs can increase warfarin levels. These drugs inhibit the metabolism of warfarin through the cytochrome P450 system, specifically the 2D9 subtype. And these are cimetidine, trimethoprim sulfamethoxazole, also known as Bactrim, and ketoconazole. Other medications that are P450 inducers can actually decrease warfarin levels and decrease the patient's INR, making it more thick. These inducers include the following medications. Some adverse effects of warfarin can include excessive bleeding, skin necrosis. Warfarin is a teratogen, remember, and warfarin can interact with multiple drugs. Warfarin-induced skin necrosis is something that should be very cautiously looked out for in patients that are on warfarin. Usually this results from a transient hypercoagulable effect that's seen when warfarin is just started in patients. Remember that protein C and protein S have the shortest half-life of all the vitamin K-dependent factors. Therefore, early on in Coumadin therapy, protein C and protein S are the first ones to go when warfarin is given to a patient. Therefore, all that's left are the procoagulant factors, which can cause a hypercoagulable effect early in therapy. This can cause skin necrosis. This skin necrosis is prevented by starting patient on a heparin originally, as well as the warfarin, and then switching to warfarin alone once the heparin level has increased to the point, as well as the warfarin level has increased to the point where they're anticoagulated. This is called bridging. Here's an example of warfarin-induced skin necrosis. The classic area that's involved in warfarin-induced skin necrosis is the breast. But any extremity can be involved in this. Some other anticoagulants that you should be aware of that are newer medications include argatroban and lepirudin. Argatroban is a newer molecule that is a direct thrombin inhibitor. Argatroban can alter PT and APTT, but the PTT is used for monitoring. There's no antidote available, and it must be carefully titrated, especially in patients with liver failure. Leparudin is another molecule that works as an anticoagulant. It's derived from leech saliva, and it is also a direct thrombin inhibitor. It is also monitored by PTT. There is no antidote, and it needs to be used cautiously in patients that have renal failure because it's cleared by the kidneys. Let's talk about thrombolytic medications. Thrombolytics work by dissolving intravascular clots that have already formed. Thrombolytics are able to activate plasmin, an enzyme that is able to digest fibrin, a component of blood clots. The thrombolytics that we're currently using include TPA, also known as alteplase, and streptokinase. TPA is used much more often than streptokinase because in streptokinase it's possible for people to form antibodies. Both of these molecules lead to cleavage of the plasminogen and production of plasmin, and as we know, plasmin can digest fibrin. This diagram shows that TPA and UPA are able to convert plasminogen to plasmin, which is able to convert fibrin to fibrin degradation products. Thrombolytics are only used intravenously for emergency management of coronary plaques and thromboses, DVTs or deep vein thromboses, pulmonary embolism, and thromboembolic strokes. It's very important that these agents are given very quickly in the natural course of the disease. Adverse effects of thrombolytics include bleeding and hemorrhage, especially when they're used along with heparin. Tranexamic acid, which is an antifibrinolytic agent, or FFP can be used to reverse the thrombolytic. But the most important thing to remember is that thrombolytic therapy is contraindicated in certain patients, and we'll talk about those. There is no absolute antidote that's available. Any patient that's had surgery within 10 days, a serious GI bleed within the last 3 months, a history of hypertension with a diastolic pressure greater than 110, any active bleeding, a previous CVA, or aortic dissection in the past should not undergo thrombolytic therapy. In this gross path image, you can see a saddle embolus. This is the pulmonary artery. And this blood clot, which is dislodged from the leg, has wedged itself in the pulmonary artery. And as you can see, any lung downstream of this pulmonary artery embolus would not receive very much blood. This patient would most likely die from a blood clot such as this. Here's another gross pathology image that shows a wedge-shaped pulmonary infarct. This is a classic image of what happens to the lung after a pulmonary embolus occurs. Here you can see a chest CT scan with contrast. On the left, the arrow is pointing at an area that's darker inside the area of the pulmonary artery. This is a pulmonary embolus. And on the right, you can see after TPA therapy, the pulmonary artery is completely clear, that the TPA molecule has broken down the clot. Talking briefly about platelets. Platelets are small cell particles that live in the bloodstream. They provide the initial hemostatic plug when there's vascular injury. They also, however, play a role in pathologic thromboses that may lead to MI, stroke, and peripheral vascular disease. Aspirin is the prototype antiplatelet agent that blocks the production of thromboxane A2 by inhibiting the cyclooxygenase enzymes. There are other types of antiplatelet drugs that are selective for the platelet, and these include the ADP receptor antagonists and the glycoprotein 2B3A inhibitors. These agents will disrupt platelet aggregation and reduce formation of platelet thrombi. The most important platelet selective agent is Plavix, or clopidogrel. Plavix is able to block ADP receptors on platelets. ADP is adenosine diphosphate. ADP is able to bind to a receptor on the platelet and activate the platelet. If you block this interaction, it's more difficult for platelets to become activated. Plavix is an alternative to aspirin for patients. Most patients that have a heart attack should be on Plavix. Some patients that have a TIA or with unstable angina should also be on Plavix. Plavix is required in patients who have had a bare metal or a drug-eluting coronary stent placed because without clopidogrel or Plavix, that stent will simply close off again. One adverse effect from clopidogrel is severe neutropenia. Let's talk about glycoprotein 2B3A inhibitors. The classic molecule in this drug family is abciximab. Abciximab is an FAB fragment of a human monoclonal antibody that's directed against the glycoprotein 2B3A inhibitor on platelets. This drug works by preventing platelet adhesion and aggregation. This drug is often used in ACS, or myocardial infarction, and often in conjunction with a procedure such as a stent or PTCA, percutaneous transluminal coronary angioplasty. The major adverse effect of these medications is bleeding. This medication is only given intravenously. Let's ask some hematology-related questions. What are the ways to reverse warfarin, both immediate and delayed? The immediate way to reverse warfarin toxicity is through fresh frozen plasma. The delayed way is through vitamin K. What is the immediate way to reverse unfractionated heparin? That would be protamine sulfate. What is the delayed way to reverse unfractionated heparin? Simply wait. Heparin is able to completely reverse itself, usually in 12 hours. What type of charge does protamine sulfate have? It's positive, and it's able to bind to unfractionated heparin, which is negatively charged. This is the way protamine sulfate inhibits heparin. What is the mechanism of warfarin? Warfarin blocks vitamin K-dependent gamma carboxylation of prothrombin and factors 2, 7, 9, and 10, as well as protein CNS. Is warfarin long or short acting? It has a long half-life, about 30 hours, and it takes 8 to 10 hours to begin activity. What is the clinical use of warfarin? It's for chronic anticoagulation. What is the contraindication? Pregnancy or patients that are at a bleeding risk or a fall risk should not take warfarin. Which pathway does it affect? The extrinsic pathway. And what does warfarin do to the PT? It prolongs or increases it. But usually we measure not the PT, but the INR, which is related to the PT. What is the mechanism of action of heparin? It catalyzes the activation of antithrombin 3, which decreases thrombin and factor 10A activity. Remember that heparin has a short half-life and it acts almost immediately. The use of heparin is, again, immediate anticoagulation in case of blood clot, stroke, angina, myocardial infarction, or DVT. The contraindication? It can be used during pregnancy because it doesn't cross the placenta. It affects the intrinsic pathway, and the blood test you should be following is the PTT in those patients. What's different about the low molecular weight heparins? Remember, they only act on factor 10A. They also inhibit the activation of factor 10A. They're more potent, and therefore you need less. They have 2 to 4 times longer of a half-life. They can be administered subcutaneously and without laboratory monitoring in general. Remember, they should not be given in patients that have renal failure. This concludes our section on anticoagulant medications, antiplatelet medications, and thrombolytics. In our next section, we will discuss chemotherapy.